Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Lessons from Lockdown, Caring for Patients with Hepatitis B Infection in the COVID-19 Era. I'm delighted to introduce our expert faculty today. I'll start with Dr. Norah Terrault. She's Professor of Medicine and Chief of Gastrointestinal and Liver Diseases at the University of Southern California in Los Angeles, California. I'm also pleased to welcome Dr. Grace Wong. She's Professor of Medicine at the Chinese University of Hong Kong and Honorary Consultant to the Division of Gastroenterology and Hepatology at the Prince of Wales Hospital, also in Hong Kong. To link to the full program online, please visit the show notes for this episode. So let's get started and hear what Drs. Terrault and Wong have to say about lessons learned in the management of hepatitis B during the COVID-19 pandemic.
Hello, I'm Norah Terrault from the University of Southern California. It's my great pleasure to join you today, and I really am excited about also welcoming my friend and colleague, Grace Wong. Grace, do you want to introduce yourself?
Thanks, Nora. I'm Grace Wong from the Chinese University of Hong Kong. So nice to meet you all here.
So what we're planning to do is review the topic of hepatitis B in the pandemic era, the COVID-19 era, really a focus on what have we learned? Like what's the good that we can take away from the pandemic and think about applying as we go forward, sort of a lessons learned from hepatitis B in this very unusual time of COVID-19. And I'm going to start by just reminding us that even prior to the pandemic, that the hepatitis B cascade of care in many countries, in the US, I'm going to show you data to start, was suboptimal. These are data from a retrospective insurance claims analysis in which they identified individuals who had chronic hepatitis B and then looked at how many of them were linked with care and how many of them were on treatment. And you can see that over a period from 2009 to 2015, this is pre-pandemic, that the proportion of individuals who were linked to care was only about a third, and less than 20% of those were on treatment. And even though we know, of course, that not every chronic hepatitis B patient warrants treatment, we know that this is vastly represents patients that are likely missing access to treatment. And in fact, the GAPS analysis suggested that. So this was prior to pandemic, and we certainly know that, and Grace, I'm sure you're going to share with us, there's been sort of shifts that happen with pandemic that make the cascade of care potentially even more challenging.
Yeah, I fully agree with you. I would say that the situation in Western Pacific region is not better, or even you may say from this bar chart that a far majority of our hepatitis B patients are not diagnosed, and even fewer of them would be linked to care and being treated and virus suppressed. So from this very nice bar chart, you can see that more than 90% of our patients remain untreated. So I would say that this probably would be something even worse during the pandemic because the diagnosis rate, the treatment rate may be affected very significantly. So we can move on to the other slide, seeing that like from this important study, again showing that pre-pandemic, we have like more than 270 million hepatitis B patients. But then you can see that quite significant of them, like roughly around 30%, should be treatment eligible. At the end of the day, less than like 10% of these patients have been on treatment. So which means that WHO estimated that globally, less than 5% of the HIV infected persons will be aware of their situation. So this is something that really troubling.
Yes, and I think that what we see is that all along that cascade is sort of a potential for impact. You highlight from your data that you have to first make the diagnosis, right? So that's sort of the first step. And then the diagnosis linked with a provider who can manage hepatitis B and that whole access to treatment. And all of those potentially perturbed by what happened with the pandemic, certainly. And I think that a lot has been stated around the diagnostic piece and the linkage to care. That's sort of the first step. And part of that was that a lot of, at least in the United States, diagnosis is largely in the hands of primary care as opposed to a specialist. And as you all know, during the pandemic, the primary care physicians were really dealing with all of the challenges related to delivering care to their patients in a COVID time, and with a lot of their patients actually being affected by COVID. And so they just didn't have the resources to be able to sort of dedicate those towards their programs around diagnostics for hepatitis B. And there are some very nice data shown by the Hepatitis B Foundation where they looked at some of the access issues, the access both to diagnostics as well as to treatment, and they found that it was staffing shortages and interruptions, inability of patients to kind of get their lab work done or get their tests performed were major issues. And telemedicine was good. I mean, for many of us, it actually was a huge kind of step forward to be able to do telemedicine, but telemedicine is not perfect. And I'd be very interested to hear what your experience was, Grace, in terms of just what your sense was about sort of access to diagnostics and to, care and what role telemedicine played.
Okay, thanks, Nora. I fully agree with you that this is something that really challenging, that because of the COVID, because of not exactly lockdown in Hong Kong, but the government will ask people not to leave their home. So some of our patients, they do not turn up for follow-up. Even they will miss their appointment to their family doctors. So I think screening has been quite challenging. There's also some opportunity because some patients, they are worried about they may have been in contact with like COVID person. They still need to come to do some tests for their COVID. And some of them may attend our emergency room. That may be one of the points that we may take the chance to screen for their viral hepatitis. In fact, for those patients who were admitted for suspected or confirmed COVID-19, we quite often we check their viral hepatitis status because in our mind, we may think that at some stage, they may need some therapy, for example, corticosteroid, that may also affect their viral hepatitis. So I think that would be one point that can really increase the awareness and screening rate for viral hepatitis. Like from this very important study in the Spain, they also have shared the experience of like a single center study showing patients with more than 16 years old right at the beginning of the COVID, last for 1.5 years. They tried to screen more patients for viral hepatitis with like surface antigen and anti-HBV. They also included the reflex test for HBV RNA if they're anti-HBV positive. And if the patient is hepatitis B surface antigen positive, they also have a reflex test to screen for Delta, so like the anti-HBV antibody. And then they want to see whether the rates of infection and linkage together will have to increase. So from this very nice screening study, they screened for more than 10,000 subjects attending their emergency room. And at the end, they would be able to pick up 87 subjects who were surface antigen positive. And even among these subjects, one of them would be also have the Delta coinfection. And then among these 87 subjects, even though it's not a big number, but I would say that it's important because quite significant of them, they were like unaware of their infection, 1/3 of them. So which means that through this screening, we will be able to pick up these patients who have been unaware of their situation and then link them to care. And at the end of the day, we find that more than 20 out of these 31 subjects, they would be willing to be linked to care. So I would say this is a nice Spanish study showing us that there would be a contact point at emergency room that we can really offer some very automated screening and at the end can link them to care. So I think this experience is very valuable.
Yes, I think it highlights that we might want to partner up with doing screenings for many things. I mean, people have talked about the possibility of people who are even coming in for COVID screening, we should be taking advantage of potentially offering them screening for hepatitis B or hepatitis C. I think being creative around, we've had such a kind of an explosion of patients seeking testing, right? Can we somehow turn that into a mechanism where going forward, we can encourage people to be stepping forward to do testing? That's probably the lesson learned here is that we can see that persons will seek out testing when they think it's something that they need to do and they see the value of it. We have long lineups of people here in Los Angeles right now seeking testing for COVID because we're going through another surge. If we could somehow turn that into, kind of the enthusiasm, the interest, the desire, the need for patients to seek out testing for hepatitis B, that could be quite transformative in terms of identifying all those individuals who are as yet undiagnosed. I want to also, if I could, ask you a little bit about telehealth, because I'm going to just highlight that here in my institution, when we started the pandemic, we were hardly doing any telehealth at all. And then, of course, we were forced, the institution was forced to get it up and running very quickly. And the other thing that happened in the United States that really helped is we started to be able to get reimbursed for doing care through telehealth. And those two things were really quite helpful. And I think they've changed the health system in the United States forever. We will now have, I think, telehealth as being part of how we take care of patients. So the ability to get access to patients, to be able to connect with them, to be able to offer, ongoing care to patients, even in lockdown and under a pandemic, was really, really, really important. But I think we all also came to appreciate that doing telemedicine isn't quite the same as seeing a patient in person.
Yeah, the situation in Hong Kong may be slightly different because Hong Kong is quite a tiny place. So most of the patients, they will still be able to travel to their doctor's clinic, even though the COVID situation is quite bad. But I would say that our healthcare system also have made these options available these days, because some patients, they still have, for whatever reason, they cannot make it to the clinic. So this has been an open option to our patients. But I would say that for patients with cirrhosis, especially those with becoming cirrhosis, there would be some challenges because we very much want to assess their sign. Like, for example, where they have quite severe ascites, which needs paracentesis and something like that. So I would say that probably telemedicine may not be able to replace everything. But for very stable subjects like those are very stable on antiviral therapy, well controlled, without any cirrhosis or any other complications, I think telemedicine definitely can replace part of our clinical care.
I agree. And for many of our patients where taking time off work, for example, was a financial burden to them, we now find that we can quickly do a telemedicine visit, on their lunch break or the coffee break, and they're very grateful actually for being able to continue to do their work and not have to take time off. So I think that is also a plus. But I think sometimes I find doing education and wanting to go through results with patients and sort of show them the results, that can be a little challenging sometimes over the screen, although we've gotten better at screen sharing and being able to do that in that format. I still really like having a laying of hands on patients. I still value that. And I think I have a better sense of how the patient, how they're really doing in their life. But I have to say, patients have really felt very favorable about this and have stated that many of them, even though they have the option now to come and see us in the clinic, say, I'm perfectly happy with the telemedicine visit and don't feel the need to come in.
Yeah, definitely. I fully agree. That would be some very valuable options for our patients. If some very conventional patients, they may still love to come to see us in person. But I would agree with you, for those those who have jobs, working, young adults, they probably would prefer a bit more for telemedicine.
We can put our efforts in terms of them taking time off to go and do their screening for HCC. Right? So if they're going to take time off, we want them to focus on the things that we know are so important from the point of view of their ongoing care. So maybe a little bit of a shift, because again, very often as specialists, we're not delivering vaccination, but yet as Hep B specialists, we care a lot about that preventive measure. And I think it's been a very interesting time to think about vaccination when there's so much emphasis on vaccination, right? On total, I think probably benefit in that individuals are much more aware of what vaccination is about, its purpose. We've come to understand that you can do sort of very large scale vaccinations. We now realize that that's very doable when there's sort of political and financial will. So maybe those are going to be very helpful to us in terms of going forward, in terms of really trying to maximize the vaccination programs, not only in places like the US and Hong Kong, but probably more importantly in other parts of the world.
Yeah, I fully agree. Yeah. In fact, now, like in many places, including Hong Kong, we have been pushing the COVID-19 vaccines very hardly. We may take the same setting to really pick up those patients who are those citizens who have not been vaccinated for hepatitis B. In Hong Kong, in fact, we have the universal vaccination for the neonates since year 1988, which means that those young adults like 33, 34 years old or younger, they should all have been vaccinated when they were born. But mainly will be those, I would say, older adults, maybe in their late 30s, 40s, 50s, who would be not vaccinated, many of them. So I guess if we already had a setting for universal COVID-19 vaccinations, that would be also another setting we may take the opportunity to really invite those unvaccinated adults for hepatitis B vaccination.
Yes, we're very fortunate that here in the United States, there's been a recent new recommendation from the ACIP and CDC about vaccination for adults. So as of November of 2021, they updated the Hep B vaccination recommendations for adults. And now it's recommended that we have universal vaccination for adults aged 19 to 59, where before it was risk-based vaccination. So this is, I think, a huge step forward and allows us to start thinking about programs where we really are trying to get a much broader message out about vaccination to the general population, recognizing that all adults, at least up to the age of 59, should be vaccinated, and then above that, a risk-based strategy. So that's a very important advance here in the United States, and hopefully we can capitalize on what we've learned about how to deliver vaccinations really, and to make them more available, and to be able to talk to patients about vaccination.
Definitely. I believe that most of the hepatitis B vaccinations are very well tolerated. I would say they're even more well tolerated than flu vaccine, COVID-19 vaccine. So I think we should really take the chance to advocate those unvaccinated adults to take it.
Yeah, agreed.
Yeah, I would also like to share a little bit about how would the two viruses, hepatitis B virus, as well as the SARS-CoV-2 virus, COVID-19, will interact, especially in like endemic region like in Hong Kong, because we still have like 6% of our adult population have chronic hepatitis B infections. So that's why recently we looked into our own local data. After a year of COVID-19 outbreak, we gathered more than 8,000 COVID-19 patients. And we classify them into three groups: no HBV infections, current HBV infection by the positive HBV surface antigen, and then some patients, they had the past infection, which means they were surface antigen negative, but they have the anti-HB core antibody positive. So we would like to see, is there any difference in terms of their outcome, in particular about the mortality and liver-related event and so on. So from this nice graph, we show that in fact, the chronic HBV infection or past HBV infection was not associated with any high chance of acute liver injury or mortality. So which means that, first of all, we can reassure our patients that if they have chronic HBV infection, they got COVID, they would not do worse in terms of their liver condition or mortality. But I would still want to highlight that these patients, especially those have not been treated with antiviral agents for Hep B, there's still a chance of having flare-up of their viral hepatitis if they need some immunosuppressive therapy like corticosteroids in moderate to severe COVID-19. In fact, in Hong Kong, we sometimes use dexamethasone for those patients who have been admitted to intensive care units. So we need a very cautious monitoring about their liver function and their viral status, because from our previous studies published a couple of years ago, we look at a large cohort of hepatitis B patients who have been treated with different duration and different doses of corticosteroids for whatever reasons. And we find that even of relatively short duration, but if the dose is quite high, so for example, here, we're saying that if the equivalent dose is more than 40 milligrams per day of prednisolone, even more than 7 days, between 1 to 4 weeks, you can appreciate the risk of having ALT flare is already increased significantly, almost double the risk. So I think we need to keep a close eye first. We need to screen for any COVID-19 patients for hepatitis B and C. And then if they need immunosuppressive therapy, monitor their viral status. And the safest approach would be start antiviral therapy for their HBV at the same time to prevent any HBV reactivation or ALT flare.
Yes, certainly that was an important message, I think, during the pandemic is you needed to be sure that you understood if a patient had hepatitis B, that we should test for it, particularly if they were going to be undergoing those therapies, as you spoke, where we'd be worried about small, but still concerned for reactivation or ALT flares. Definitely. And I know AASLD and I know other societies and experts put out guidance around how to manage chronic liver disease during the pandemic. This was helpful to us. I mean, we were feeling the need for information as we were caring for our patients. And shown here is some of the specific guidance given by the AASLD. And I think we've touched on several of these already in our discussion. One is, when we were in lockdown situations or not able to have patients come in to visit us in the clinic, was really to optimize and leverage the telemedicine services. And I think I highlighted that definitely became very much the standard, and now I think is something that we'll continue to use as is best suited for the patient. That we were really very focused on ensuring that our patients didn't miss out on their monitoring and their HCC surveillance. And that was stressed very much by this guidance that we should really try to hang on to keeping them on their surveillance pathway, recognizing that sometimes they would be off by a few months because they really truly couldn't get access to their radiology services. But we were really emphasizing the need to try to stay on target with that. And then to remember that if you have a patient who has elevated liver tests that in the setting of COVID, that could be due to COVID, but you have to think about, what else might be going on. So this is a nice graphic that sort of highlights that if a patient had abdominal chemistry, it was suggested that you would check for hepatitis A, B, and C, and B and C, I think, would be the big ones. Review medications, which could be culprit, but then really very minimal additional workup. You might consider imaging if you had a strong suspicion of, say, a biliary complication, a mass, but generally, otherwise it was just follow the patients, and then if they weren't improving, then go down a much more detailed evaluation. I could just ask you, Grace, in terms of your experience, did you find that you identified new patients with hepatitis B because they presented with COVID?
Yes, we do, because that would be probably the first time the patient really came to the hospital. Because in Hong Kong, the policy is all COVID-19 patients have to be hospitalized. That's one special point in Hong Kong. And that would be the chance that the patient have a formal medical assessment. So usually we go through a very comprehensive history taking, and then we, because hepatitis B is still per preference here, so very often we check that for the patients. So we find that more than like half of our COVID-19 patients in Hong Kong, they had never been checked for any viral hepatitis in the past. And that would be the first time they came to the hospital and had a chance that someone really screened for them. So we did pick up quite a handful of patients who were not known to have chronic hepatitis B in the past. But after we pick them up, they would then link them to care after they have recovered from COVID-19. So I think in Hong Kong, the situation is kind of special because we have to hospitalize all COVID-19 patients anyway. So that would be a chance that to have more comprehensive medical assessment for them.
Well, we're at our time, Grace. It's been wonderful, really, to have the conversation with you, as always, a pleasure. And I just thought maybe we'd close with just a few take-home messages for our listeners today in terms of key lessons that we feel we've learned about hepatitis B in this setting that we hope will be able to take us forward. Maybe I'll let you start, Grace.
Okay, thanks, Nora. Yeah, I think first thing is that would be a good opportunity for us to really increase vaccination screening in this special time because we have setting for universal COVID vaccination set up anyway. So we can really increase the vaccination by covering, giving hepatitis B vaccination maybe at the same setting. And for the screening and diagnosis, we like what we just discussed. In fact, when the patient comes to seek medical health, that may be one good opportunity for us to really check and screen for viral hepatitis, in particular hepatitis B in Hong Kong, but in other parts of the world, I think both hepatitis B and C should be screened. And also for the treatment part, yes, again, that would be some opportunity for us to reassess whether the patient really need treatment for the hepatitis B, especially for COVID-19 patients, they need immunosuppressive therapy. That would be one thing we have to bear in mind when the patient was screened positive for hepatitis B.
Great. Yes, you've highlighted all of, I think, the key areas. For me, I think that what's emerged is the role of telehealth. Both some good things about it, maybe some limitations, but I think it's going to play an increasing role in managing patients who really cannot afford the time or have more difficulty being linked with specialists. I think this provides an opportunity to potentially streamline those linkages and allow those individuals to remain in care. And I'm hopeful that also really the information about being able to educate a population about a condition and then mobilize them towards seeking care might be an important lesson we take away from this to really raise awareness overall about hepatitis B, its linkage in particular with liver cancer that might motivate more people on a really in a national basis to seek out testing, get vaccinated if they're remain susceptible, and for those that are testing positive, get more likely to get them into treatment. So I hope that sort of this idea of we've been dealing with a pandemic, and now let's see if we can turn individuals into thinking about other health issues with that same sort of fervor, I would say. Well, I want to thank the audience very much for joining us today. It's been an unusual time, certainly this pandemic, but we are, I think, learning things that hopefully ultimately will lead to progress with hepatitis B, and in particular, helping us to meet the elimination goals that we're all have in view for 2030 and beyond. And I want to thank again Grace Wong for joining me. Absolutely a pleasure, as always, to spend time with you.
Okay, thanks, Nora. Thanks, everyone. Okay, see you next time.
Thank you so very much to Drs. Terrault and Wong for sharing that engaging discussion, and thanks to our listeners for joining in. As a reminder, to view the full educational program online, Lessons from Lockdown, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics.